Oh, how's it going? I am Dr. Lindsay Huey, lead faculty for extremity management, along with Dr. Mark Gallant. I am so excited to speak with you on a clinical Tuesday. As you all know, it is my favorite day of the week. Um, Mark and I have a load of courses coming up in 2023. We are super stacked in January and February, and we're so eager for you to join us. Our first courses are January 14th and 15th. Join me in Paoli with Brady out of Onward Philly. If you're in that area, we'd love to see you. Mark's course that weekend is actually full the 14th and 15th, but then there's another opportunity to jump right in the next weekend if you can't make the 14th, 15th, the 21st, and 22nd in Marysville, Ohio. And then just check us out on ptonice.com because there's a host more of courses, and we'd love to see you. So today's topic at hand, what are we going to chat about? Well, what I can't wait to chat with you about is the IT ban and a little bit of an update in our nomenclature. So what's interesting is last year, this time, I actually spoke with you all about an update in the literature from Geisler et al. In 2021. And this year, I want to at the end of this year to kind of challenge us to think about our IT ban care a little bit differently. And it starts with a name. So today's title is Labels Limit in IT ban care. And I really want to unpack that if we can update how we name it in our nomenclature, we can actually do a lot better in our care. So let's just review general presentation of IT band pain. It's lateral knee pain that occurs in those who participate in repetitive flexion to an extension activity. So think running, cycling, even tennis, weightlifting. In particular, our military populations are affected by this because of that, a lot of repetitive action in running. Our dominant athletes that we're going to see are humans across the lifespan, young to old though, will be our runners. Upon examination, briefly, what will we find? It's those with tenderness to palpation at that lateral femoral epicondyle. They'll have a positive Noble compression test, and then they will have reproduction of pain with their running task, possibly with squatting, and then stair climbing. In particular, it'll be stair descent. And that's where we see that hip extension that's coupled with knee flexion. And so the TFL is working eccentrically. That's why we'll see it in particular in descent and or in our downward running tasks. So let's first talk nomenclature. So I want to start with a quote. Shakespeare said, "What's in a name? That which we call rose by any other name would smell just as sweet." And then James Clear, in a more modern way, says labels limit. So in short, we limit our understanding and our patient's understanding of what iliotibial band pain is when we decide to distinguish it as a friction or an impingement problem. In its most basic form, it is really neither. It's more complex than that, right? We're dealing with humans. And if we don't really take the time to see the multifactorial reasons related to IT band pain and care, we're going to really limit our patient's rehab experience and progress. As with all musculoskeletal conditions, right, it's a multifactorial experience. So let me take you on the journey for those that haven't listened to the podcast from last year. What was thought about the IT band? So we thought the IT band is tethered. And we thought it was a friction thing, right? So that we thought that what was happening is the IT band is moving back and forth along that lateral femoral epicondyle as someone is running, right? We used to tell patients, give them that explanation about that snapping across. And what we found is that's not really true in cadaveric studies. So a dead body, we can't move that thing. So the ITB is tethered so much, it doesn't traverse that lateral femoral epicondyle when you see the knee going from knee flexion to extension. So it's not a friction issue. And that was confirmed in that Geisler 2021 article review, and I'll link these at the end. We even have a now more recent 2022 review out of Sports Medicine Journal that confirms that. And our most recent kind of thought in that 2021 review and now this 2022 review is that it's actually a compression or impingement issue happening at the knee, meaning the IT band is actually pinching bone at the and there's a highly innervated fat pad there. So that's the pain generator. So these two articles, that's kind of like our best evidence now. It's not movement at the IT band, but rather it's a compression source. I would like to take some liberties here and say that neither friction, because that's been disproven, that movement, and neither compression is really good enough to describe what's going on when our humans have IT band impingement or, have IT band pain symptoms, right? I want us to a call to action to get rid of the word impingement, which last year I told you to call it that. So I'm calling myself on this as well. I want to suggest a rewrite that we say less better and call it iliotibial band pain. When we think about pain, right, ISPI's most basic definition, it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. When there is IT band pain, we don't actually know for sure if it's friction or compression. That's just what is really theorized based on those cadaveric studies. When we think about the humans that you see with IT band pain, it's not just a bioanatomical reason, right? Especially our long-term runners, right? They didn't just all of a sudden get a pinch. The biomechanical reasons aren't good enough, right? Yes, there might be some asymmetry in the run, and we do have to look at gait analysis. But I'd love us to consider it's more to do with environmental change, specifically environmental change in the direct human and in the environment in which they run. And those are the two things that we really need to recognize in the pain experience of that individual. So if we, in a very simplified way, consider the direct container, the human, right? Does this human have increased stress, decreased sleep, maybe increased sweets around the holidays, celebrating Christmas, Hanukkah, Kwanzaa, whatever, more processed foods? Maybe they are dehydrated, maybe not drinking enough water because it's cold outside and their body doesn't feel like it needs it. These direct environmental things in a human are what need to be assessed and addressed. And then that outside environment, what we actually, when you think about any human you've treated, right, with that lateral knee pain that looks like it's related to that iliotibial band, what has changed in their outside environment? What we usually see is a training spike, right, in either volume. So, right, they've either increased their distance, they've increased their speed, they've changed their running direction. Maybe they started doing banked running because it's cold, so they're running indoors on a track. What we often see in a lot of our runners where this flares up is they've started downhill running. This is a primary culprit for iliotibial band pain to occur because of that eccentric control requirement. These are the things that we really need to look at and assess. We will keep our humans running if we change the environmental contributors. Never stop the runner. Runners love running. I know I hate running. I don't know how runners love running, but the runners that are true runners, they love it. And our job is to keep them running. And by giving them the label of this is friction at the lateral femoral epicondyle, or this is impingement, guess what? That invokes fear to move, right? That bioanatomical label and explanation doesn't make that human want to run. In fact, it probably makes them fearful to want to run. Let's change the name, let's change the nomenclature in our narrative and address more of those environmental considerations, right? So that human that did a quick running distance ramp up or speed, help them make a plan to go down to their previously sustained mileage that doesn't increase irritability, right? Maybe you're adjusting their speed or returning them to more flat running ground until symptoms come down. Maybe it's making them do intervals, walk, run if they're really flared up, right? If they did a super long run. But we want to really change that environmental thing first, but keep that human running. The other thing is direct ecosystem influences, right? Give them education about the multifactorial nature of that pain experience. Don't give them the bioanatomical cause. Some of our engineers like to know the theories. You can tell them, but you can tell them it's more related to that spike, right? Or change in their running terrain. It's not their shoes, right? That didn't magically just change. Address any personal stressors, address sleep hygiene, make sure they're getting enough fuel, right? If they're ramping up their running, everyone has New Year's resolutions coming up, and some are starting them early. Make sure they're getting enough protein to support activity and enough hydration. And of course, we'll use our manual therapy, right, for symptom modulation to keep the humans running. That's our number one goal when someone has that iliotibial band pain, is to keep them running. And some of our favorite go-tos are myofascial decompression and dry needling to the TFL, the glute max, and vastus lateralis. Those are our go-to targets that really help modulate and alleviate symptoms. And come to our course to learn more about that and how to utilize that manual therapy care. And we'll even use taping and orthotics as a temporary therapeutic tool to reduce symptoms and to keep, again, that human running. Other things we'll do to build up the direct system are quad and hip strengthening, right, to help promote good frontal plane control. And again, as earlier mentioned, addressing any running mechanic issues if they are on board. Our favorite ways to attack that frontal plane control, right, to reduce that femoral adduction internal rotation that we'll often see with people with IT band pain. Our favorites are split squats, lateral step down, and doing some reactive neuromuscular training. And then for extra resilience when pain comes down, adding in some plyometric work that challenges frontal plane control. But really, team, my main focus for today, besides kind of those our go-to manual therapy and exercise treatments, is that let's help our humans attack the new year and their running goals by keeping them running, keeping them understanding the multifactorial nature of this condition. Don't blame it on one anatomical source. Instead, talk about the direct influencers of them as the human, right? Stress, sleep hygiene, protein, hydration, and give them holistic buoys, right, that empower them to keep running, right, whether it's changing in running terrain, speed, distance, but keep them on the road or keep them trail running, whatever it is that brings them joy. And finally, let's say less better by just calling it iliotibial band pain to prevent fear and over medicalization, right? Let's get rid of friction, impingement, compression, as those tend to invoke bioanatomical fear and reduced locus of control for our humans. Cheers to 2023 and your runners with IT band pain. May it be a year that is empowering and energizing for them as runners and for you all. I hope everyone, whatever you celebrated this past week, whether it was Hanukkah, Christmas, Kwanzaa, or you just celebrated some time, downtime, I hope you really enjoyed it. And thanks for tuning in today. Cheers, everyone. Happy Tuesday.